Welcome everyone and good evening, and thank you for joining us for this year's Royal College of Pathologists BDIAP Taster Event. I'm Anghara Davis. I'm Clinical Director for Publishing and Engagement at the College, and in the past I've had the privilege of being the College's lead for undergraduate and foundation. And this is now our 6th Taster event, so I'm delighted to be able to welcome you all this evening. It's fantastic that so many of you out there are interested about finding out more about the pathology disciplines. You'll notice that your microphones are muted and videos are turned off in the webinar format so that we have fewer distractions. You will be able to ask questions through the Q&A later on during the panel discussion. If you're using Twitter, we're using the hashtag #WeLovePathology. So this slide shows you the programme for the next hour and a half or so. First of all, we'll be hearing from our president, Dr. Bernie Crowell, and after that, we'll be introducing some of our opportunities for foundation doctors and hearing from one of our current foundation fellows, Dr. Lily Schofield, and one of our LIFT trainees, Dr. Taranveer Kula, about their experiences in pathology. I'll then be handing over to Dr. Matt Clark, NIHR clinical lecturer and ST5 in diagnostic neuropathology, who is a past chair of the college's trainee advisory committee. And Matt is going to talk you through an interactive mystery case, which will give you a taste of several pathology specialties with the help of our Q&A panel, who I'll introduce shortly. And Matt will then go on to chair the Q&A session itself. I hope that many of you had a chance to watch the specialty videos which panel members have prepared. The Q&A is your opportunity to ask questions to all the panelists about their specialties, about the training, selection and interview processes. We'll then have a short presentation on behalf of our sponsors, the BDIAP, who we're very grateful for sponsoring tonight's session, and then some advice on how to organise taster days and some of the many other opportunities that the college offers for students and doctors who haven't yet entered pathology training. These are the guest panelists joining us for the Q&A panel. We're really very grateful to all of them for finding time to join us this evening. For chemical pathology, we have Dr. Jessica Johnson. For haematology, we have Dr. Thomas Erblich and Dr. Dana Warsell. For histopathology, we have Dr. Elsa Chio and Dr. Katie Allen. For neuropathology, we have Dr. Matt Clark. For immunology, Dr. Patrick Young. For medical microbiology and virology and infection training, Dr. Ian Blythe. And we'll also be joined by the RCPath Director of Learning, Joanne Brinklow. Now, this is a word cloud which we created a couple of years ago from words which pre-pathology training doctors and medical students have told us that they associate with pathology. So the bigger the word, the more often it was cited. And what really stands out alongside the diagnosis and detective aspect is a very strong reflection of the more intellectual aspects of pathology with words like research, science, academic and analytical. So it's good to see that these continue to be highly valued by potential future pathologists. And it's also good to see words like diverse and varied, because we are a very diverse bunch of people in all sorts of ways and with a huge variety of work. So now I have the pleasure of handing over to our president, Dr. Bernie Crowell. Bernie is a consultant chemical pathologist based in Aberdeen. And thank you so much, Bernie, for finding time to join us this evening. And over to you.
Thank you very much. And good evening, everyone. It's a pleasure to join you. And it's a very great privilege for me to be acting as president of this Royal College. I've been in post since November of last year, and I'll be in post for a 3-year period ending in November of 2026. I guess I'll go straight into the obvious question. Why would you want to choose pathology as a career? The first thing to point out is, of course, that pathology disciplines are all very different. There are 17 main pathology disciplines, and even when you look beyond that, even within each discipline, there are various subspecialties and various ways of working. And so, me as a chemical pathologist, I can guarantee I will work very differently from the chemical pathologists that work elsewhere across the UK. There are so many options for us. Clearly, the first difference that many people point out about working in pathology disciplines is that you're less likely to be face to face with patients, and of course some people will say, "Oh well, you're not a real doctor. You're not dealing with patients directly," and well, for some of our disciplines that might be true. For many of our disciplines, it's not true. So, as a chemical pathologist, for example, I spend most of my time with direct patient facing activities. Yes, I look after laboratory work as well. But for example, today I spent the morning doing a 3.5 hour ward round, and in the afternoon I had patients in a clinic. So it's in many cases it is very different. But obviously with other disciplines such as cell path, then yes, you are more or less a step back from direct patient care. But nevertheless, you're very much ingrained as an important part of the patient pathway. And working in that sort of step back position doesn't mean that your contribution is any more valuable. Indeed, many of us make the choice to work in pathology because it's where our contribution can be the best it possibly can. And so, we need to always think that in mind when we're considering a career in path, and it doesn't mean that you're contributing any less, and in many cases you're contributing a lot more. Certainly when I look back around the choices I had when I was at your stage 30 years ago, for me there were two main things that I really liked. One was science and one was medicine. And so pathology, I think, was a great fit for me and allowed me to, think about combining my love of science with my love of medicine. And that was one of the big attractions that certainly, brought me into clinical biochemistry. That said, it wasn't something that I've always wanted to do. It was for and again for many of us, it's sheer chance and opportunism. I was very much set up for a career in general medicine, and I found myself actually unemployed for a period of time, and a job came up in clinical chemistry, and I had no idea what it was really, to be honest. But I went for it, and it was the best decision I've ever made. Um, Obviously, in today's society, it's certainly much more advantageous to be in a profession that gives you alternative lifestyle choices as well. And certainly, pathology disciplines are more likely to be very flexible for those that want to choose that kind of career setup, both in training but also in your professional careers. And we're also less likely to do on-call work. But again, that varies. For the last 30 years, I've been doing a 1 in 3 on call, and it's particularly light, but nevertheless, it still keeps me tied down. But it is very variable, and the variation is something that I think we all enjoy, and it gives us the opportunity to choose different things. The thing I want to finish on is the importance of Royal Colleges. Within your careers should you choose to join a pathology discipline. And I think Royal Colleges are incredibly important. They're incredibly important during training because they support training. They carry out and put on the examinations and take part in the assessment processes, and provide a lot of the education. And we've got wonderful online things developing like the pathology portal, which will help support that. But in your future careers, but colleges are incredibly important as well. And um, we do lots of things such as standards and guidelines. We lobby government. We stand up for the disciplines, and we make sure that our voices are heard. And there's a huge array of different things that colleges do. In the end, colleges are not them and us. Colleges are its members, and it's important that we don't forget that, because many of you who hopefully will decide to take up pathology disciplines will in future years become consultants, and in future years beyond that, and within those jobs become fellows and members of this college and provide direct input. And maybe one day you'll be sitting in my seat. So thank you very much for the opportunity to speak to you. You're going to hear lots of different things from lots of experts tonight, and I would thoroughly recommend that you think very carefully about choosing a pathology discipline, but in the end, just do it. Thank you.
Thanks very much, Bernie, for that great introduction to pathology. Thank you very much. Now, let me just find the slide. So, what are the opportunities to explore pathology specialties in foundation, for example? Well, there have been a few developments over the past few years. So I'm just going to talk to you about a couple of those. The first one is longitudinal integrated foundation training, or LIFT, in pathology, which is available in some regions. Now, LIFT is an arrangement where which you may be familiar with. It's mainly, we're familiar with it for general practice training, actually, but it's a foundation arrangement where you work 4 days a week in your acute medical or surgical or other discipline, and 1 day a week in something else, but you do that for the entire year. So in this case, that something else would be pathology. And we currently have pathology-related lifts in a range of specialties. They exist in Wales, and I know that they also exist in Southampton. And there may be some other ones being developed as I speak. These are a really excellent opportunity to try out pathology and get involved in a department and really get to know a department during your foundation years. So that is one thing to look out for. Secondly, we have our foundation fellowship schemes. These are a really great opportunity for foundation doctors who are rotating through any foundation post which contains a pathology discipline within it. So that might be histopathology, hematology, medical microbiology, or any of the other specialties that the college represents. You can find out more about the various benefits and opportunities that are offered to foundation fellows on our website. An evaluation of our first cohort was found that they had received this very positively, with 96% of our foundation fellows saying it had been a worthwhile experience, 96% also saying that it would help their career, and 66% saying that it had positively influenced their choice of career. Applications have recently closed for the current round, but this is something to think about for next year if you're either an undergraduate or if you're an FY1 with your second foundation year next year. And I'm delighted that we can include one of our foundation fellows in this evening's event. Dr. Lily Schofield is one of our current cohort, and although unfortunately she has clinical duties tonight, she's been able to create a recorded presentation, which we'll play now, explaining her experience as a foundation fellow. So I think the team now is going to play Lily's video.
Hi, I'm Lily Schofield. I'm an academic foundation doctor at King's College Hospital, and I am a current foundation fellow with the Royal College of Pathologists for the current academic year. I'm going to talk to you today about haematology and foundation training and how the fellowship has benefited me. So those who are eligible is anyone who's undertaking a pathology-related specialty as part of the rotation. The full list of these specialties is available on the college website. I personally applied in the summer of F1 as I was carrying out 2 haematology blocks within my F2 year, so that was academic haematology and clinical haematology. I had to submit my CV and a 250-word statement, and there are 25 fellowships available each year, and I was lucky to be awarded one. So we're just going to talk about my clinical haematology experience first. So the haematology rotation was 4 months at the beginning of F2. I was lucky to work in a very large centre, both for bone marrow transplant and cellular therapies, but also we had a large sickle cell population in our patient demographic. We served 4 haematology wards and outliers, so it was a large patient load, but I was part of a great team, which I was really lucky, involved in the day-to-day care of ward patients, as well as there was opportunities for MDTs, clinics, and laboratory opportunities for anyone who sought them. It definitely was a steep learning curve, as I feel as haematology is sometimes not covered in lots of depth at medical school. So there's lots of new things for me to learn, but I enjoyed doing it, and I was involved with a great team of colleagues. Here are some photos of my time at King's. So on the left was my first day in haematology. We were very lucky to have a Leukemia UK ambulatory bone marrow unit, where the patients could come in as day cases, and some of my lovely team are on the right. Next, I'm going to talk to you about my academic haematology rotation. So this was in the final 4 months of F2. I carried out my Specialised Foundation Programme project in CAR T-cell therapy for multiple myeloma, supervised by Dr. Ruben Benjamin at the Rain Institute at KCL. My project was lab-based and there was a clinical project side by side, and I was lucky enough to carry out a focus group with myeloma patients as part of the patient and public involvement in my research. I also completed other qualifications which were useful for my clinical development during this time, as I had more time in my academic block, and I had no clinical commitment at that time. Also, I was involved in education. I was an OSCE examiner and an ILS instructor, and I enjoyed being part of a lab, as I had been kind of in medical school, but it was great to carry out my project with such great scientists. So this is a summary of my outputs, not just from the academic block, but from F1 and F2. So I sat some exams alongside my clinical work, which is always a challenge. I was lucky enough to present some of my research, both locally and internationally, with oral and poster presentations. I was awarded an array of grants and prizes and awards, including the Foundation Fellowship from the Royal College of Pathologists. I managed to publish some articles, and also I was actively involved in audit and quality improvement, as well as being the Specialised Foundation Programme representative for London. So I was involved in leadership in that capacity. Here are some photographs of my academic pursuits during my foundation years. So the top left is when I was presenting in the European Society of Intensive Care Medicine in Milan. And if you follow that round to the left, there was my the British Society of Haematology oral presentation. And on the far right, I was most recently presenting at the King's Health Partners Haematology Research Away Day. And you can see a big group of us all who were involved with that conference at the bottom. And I think what I want to get across is that it's very important not just to get involved in research, but also to present that and share that with colleagues in order to disseminate your work. Next, I'm going to be talking about the fellowship and how it benefited me. So first of all, academic credibility. So by having the fellowship, it allowed me to get the attention of the most competitive supervisors and work in a very prestigious lab. Also, I was lucky enough you get sent the college bulletin, so I read that on a monthly basis. The college are very proactive in promoting careers in pathology, so my eyes were open to some opportunities I didn't even know existed prior to having a fellowship. You get free attendance in college specialty meetings, access to important educational resources. I had a greater understanding of the role of the college, which previously I wasn't that aware of. And also, of course, it's a portfolio boost, and it adds to your CV for specialty applications, which are becoming increasingly competitive. And also, I'm extremely grateful that the fellowship has given me opportunities like today, where I'm able to share my work with you. So I'm just going to talk about some tips and tricks for foundation years. So I wanted to emphasise it's important to make the most of your clinical opportunities. Foundation years are primarily to make you grow as a doctor, and it's important to keep an open mind about those opportunities. So make the most of anything that sort of comes across your path. Don't be afraid to ask seniors for help in your foundation years. That's what they're there for. They're there to teach you and they're there to give advice. If you are research inclined, do seek research opportunities. And even if you're not, think about getting involved in projects which may interest you, as these are always useful for specialty applications. Definitely make the most of your study leave and be aware early on what your entitlement is. And make sure you're looking after yourselves. It's a very difficult sort of 2 years of foundation training, and you may need to make sure that you put yourself first so that your work follows that. Apply for fellowships like this one, and make sure you build your CV early for those specialty applications and future opportunities. So thank you very much. I'm sorry I can't be there in person today due to clinical commitments, but please do contact me if you have any questions at all about haematology, F2 in general, or about the fellowship. And I'm really grateful to the college for inviting me to speak today. Thank you.
Well, great to hear about Lily's experience as an RCPath Foundation Fellow. And now I'm also very, very pleased that we can hear from a pathology lift doctor who last year did a microbiology and infection lift in Swansea. So I'd like to welcome Dr. Taran Viakula to speak about his lift experience in medical microbiology and infection. Thanks very much, Taran.
Okay, no worries. Thank you very much for having me. I will just share my screen. Okie doke. So yeah, my name is Taran. I'm a current F2 in Cardiff and Vale Health Board, and I'm just going to talk about my Lift F1 time in ID Micro over in Swansea Bay University Health Board. So firstly, what is LIFT? So I think Prof Davies has already covered a little bit about LIFT. So essentially just sort of stands for Longitudinal Integrated Foundation Training. So essentially you'll end up spending 1 day a week in an allocated specialty. So that may be histopathology, hematology, radiology, or in my case, microbiology and infectious diseases. And essentially you'll be gaining experience and skills in an additional specialty. So it's like doing 4 rotations instead of 3. In your normal 5 day working week, you'll spend 1 day in that sort of allocated specialty, and that 1 day will be protected time. So there are a few deaneries offering LIFT programs. So that includes sort of Yorkshire and Humber, Northwest and Wales. So for me, that would look like every Wednesday I'd join the ID or micro team for the day. And there I would essentially attend consultant-led rounds where we would review complex medical or surgical patients in different settings and essentially provide advice on, sort of antibiotic prescribing and sort of review patients from an infection point of view. And then in addition to that, we'd also attend MDTs, such as the TNO MDT or the hematology MDT, and essentially discuss patients from those different specialties who quite often have quite complex medical or surgical backgrounds. And then sort of my favourite part of the LIFT programme was definitely attending bench rounds, which was essentially where we'd review culture samples. And I received a lot of teaching and was essentially taught how to use a microscope and the different characteristics of bacteria and the different testing that goes into place to sort of identify the different bacteria present in a culture sample. And I was actually able to visualize this sort of through the microscope and also the testing process as well. And so it was all just sort of really interesting in actually being able to see that in play. And then in addition to that, I was also able to observe seniors providing micro advice down the phone. As part of that, I was also able to actually try my hand out at providing advice sort of with things like calling out positive C. diff results, and then sort of correlating that to the patient's clinical status, and then providing advice based off of sort of senior supervision and guidance. And it was just sort of a really good experience in terms of having seniors sort of talk you through their thinking process behind why they're providing that advice, and then that sort of helping my understanding. In addition to that, I was also involved in a few different projects, and one that I'm most proud of is sort of being involved in the Bugs Life podcast series, which I'll talk a little bit about at the end if there's time. So essentially, my overall experience of doing sort of ID Micro lift is that I've thoroughly enjoyed it, and I cannot recommend it enough. In terms of other pathology lift programs as well, I know some of my colleagues did the histopathology lift, for example, and they thoroughly enjoyed it as well. And I just feel like the training that I received as part of my lift placement was actually better than the training that I received in my actual foundation blocks. And I think one of the things that really stood out was having consultants with you, often one-to-one or one-on-two, and essentially being able to explain their thought process and their decision-making process behind why they would instigate certain investigations or management plans. And in addition to that, pointing out quite rare clinical findings as well. And I felt that this definitely improved my own confidence in reviewing and investigating patients and coming up with my own management plans. And I definitely noticed that, especially on call when managing sort of patients with, infectious diseases. And it was also nice to have a consistent team throughout the entire year. So, obviously during your foundation program, you're rotating around different specialties every 4 months. And so by the time you get to the end of the 4-month block, when you finally figured out how everything works, who everyone is, you're sort of moving on to the next specialty. Whereas, here you're sort of with the same team, 1 day a week. And it was just quite nice, having people who sort of knew who you were, how things worked. And just sort of being able to ask for advice about things like, applications and things like that, and also being involved in projects. And I feel like just generally I've learned so much about the specialty, from treating infections and the different bacteria and other microorganisms. And just sort of generally developed so many different skills, from being careful with antibiotic use, and then in addition to that, just sort of communicating with different members of the healthcare team, really. So just as I mentioned earlier, one thing that I did get to work on during my lift placement was the Bugs Life podcast. So just sort of quickly, as a lift trainee, I had the pleasure and the opportunity to sort of get involved with the Bugs Life podcast, which is essentially an educational podcast series which covers topics related to infectious diseases and microbiology. And so far, over the 1.5 years that we've been doing it, we've been able to create about 40 podcasts, sort of providing teaching to healthcare professionals and medical students on various different things related to ID Micro, so from hospital-acquired pneumonias all the way to infective endocarditis. So if you are interested in checking out the series, then please do scan the QR code or visit the website with the link below, or the Twitter handle. And also they are on the pathology portal as well. So my role in the Bugs Life podcast has been to create a few of the podcasts, but also to record and organize the podcast, and also to choose some of the topics that we cover. So that's been sort of my experience of lift, and I hope I've sort of been able to explain it well, and I hope I've been able to provide light on a program that's not necessarily well known. So yeah, please feel free to email me any questions if you do have any. So thank you very much.
Thank you very much, Taran, and great to hear your experience, and congratulations on a fantastic podcast series, which I highly recommend if you have a chance to take a look at it.
Thank you.
It's now time for me to hand over to Dr. Matt Clark, who's NIHR Clinical Lecturer and ST5 in Neuropathology, and he's going to present our mystery case and then chair our Q&A session with the panel. So over to you, Matt.
Thanks very much, Howard, and pleasure to meet you all online tonight. Lovely to have so many people with us. So my task now is to run through the mystery case discussion. So hopefully this is with the help of my colleagues who have very kindly joined us as the panel tonight, we're going to hopefully showcase to you how the different specialties can work together in pathology to help with the diagnosis and subsequent management of quite a complex case. So we'll run through this and see what you think. There's going to be various different points where we'll be looking for your interaction as well. So let's just introduce the patient first of all. So this is David. He's a 47-year-old man who's generally fit and well, no significant past medical history, but he's had lower abdominal pain for the last few months associated with occasional specks of blood in his stools. And he's been feeling very tired with some associated weight loss as well. And quite importantly, family have noticed that things aren't quite right with him as well. So as a result of that, he takes himself to see his GP. And the GP, as usual, part of the standard process, would take a history. Notes also on examination that he's got quite pale conjunctiva and mucous membranes, and also comments about some associated weight loss compared to previous visits as well. He's got a normal temperature, but he's noted on a further examination to have some discomfort in the left lower quadrant on his abdominal examination as well. And as part of the routine makeup for subsequent tests that the GP wants to do, they decide to do some full blood counts, use an ease, and see what those initial results show before moving on to any subsequent investigations. So we've got the results of our full blood count here, and I've highlighted in red the particular results that show some abnormalities here. What I'm going to do now is just go to our haematology colleagues. So I think we've got Thomas and Dana on the line tonight. Thomas, can I come to you? What do you think about these results here in the context of what we've just been talking about with the initial history from our patient?
Yeah, thank you. Well, of course, what you see is a low hemoglobin and a low MCV. So that's the first clear abnormalities, which are nicely highlighted in red as well, so that nobody can miss it. White cell count is normal, platelets are normal, so it's a problem with the red cell lineage, so to say. But basically, we can say this patient has a microcytic anemia. Now, at that stage, with the information that we have available, you were thinking somebody who has speckles of blood in his bowel motions, perhaps may have chronic GI bleeding or long-standing GI bleeding, has been losing blood. So that would be my concern, that is potentially has developed a iron deficiency anemia. Thanks, and of course, we would be concerned about malignancy in that setting, or perhaps about inflammatory bowel disease as well.
Thank you, Thomas. Is there, as a haematologist, is there anything you'd be particularly wanting to do next, or advising the team that are looking after, or the GP at the moment, what to do next exactly?
Yeah, absolutely. And in a patient like this, I mean, in the first instance, we would ask the hematinics just to confirm whether or not this is microcytic anemia due to iron loss. So we get a ferritin, get a transferrin saturation, and then we'll take it from there. But of course, we would also say, well, we need to investigate the cause of the bleeding and the anemia, not just diagnose an iron deficiency.
That's brilliant. Thanks very much, Thomas. We'll now take a look at our USANEs and LFT results and things. So we've got quite, again, just highlighting some of the derangements here, particularly associated with the albumin and the LFTs. And we've also got some ferritin and iron studies. As Thomas mentioned, this would be quite useful in the context of what we saw with our full blood count initially. I'm going to come to Jessica now. Jessica is one of our chemical pathology colleagues. What do you think about these results that we've got here at the moment? And what would be your thought process based on the history as well?
So you've got a history of a sort of iron deficiency anemia with a normal ferritin, but the serum iron and transferrin sort of go alongside with your iron deficiency anemia. It's one of the things when we, as a chemical pathologist, is that we don't just look at the fact that the ferritin is normal and go, that means that it's normal, because a ferritin can be falsely elevated with inflammation. And so a normal or even a raised ferritin might, if that's the only blood test you're doing, as a lot of people just use a ferritin for screening tests for iron deficiency anemia, doesn't always give the whole picture, which is useful to know. Again, you've got the deranged LFTs, which could be, it could go along with, we've got an iron deficiency anemia, we've got a history, we've got bleeding, we've got a history of something showing inflammation. So you do have It could be something like ulcerative colitis with accompanying PSC possibly, or it could be malignancy would sort of be your two sort of things to worry about, both of which would probably end up with an endoscopy anyway. So.
Thanks, Jessica. Is there anything else from your viewpoint as a chemical pathologist that you'd want to perhaps recommend them considering doing as well?
So I don't know if you would bother doing, like, for example, a fit test in this scenario, because you, as I said, you're already wanting to go for an endoscopy anyway, so it wouldn't really add anything extra.
Okay, that's brilliant. Thanks very much, Jessica, for your input into that's really helpful. So let's go on to get further clinical updates. We've got quite a picture that this patient is quite unwell just from a few sets of blood results that we've got so far. And the GP is particularly concerned about this given the clinical history that we've got. She's suspicious that there may be an underlying cancer, as we've mentioned already from our experts. And they've organised this for some rapid investigations to explore this further. So I'm just going to come to our first poll. So it'd be great to hear from you guys about what you would think would be the best thing to do next. So Carla, if we can just start the first poll, if that's okay. And we'll just give you a few seconds to vote for which one would be your first choice investigation at this particular stage. It's just a couple more seconds and we'll close it there, Carla. And can we see the result, what that was? So colonoscopy was the most popular one, and I agree. Perhaps that would be the key thing to look at this stage as well. But perhaps the next most popular was about the CT abdomen, and again thinking about the FT derangements, that might be something to look at, or at least do some form of imaging of the liver, whether that's an ultrasound or going for a full CT at the moment. That would again be up to the clinical team to decide. But yes, so let's have a look at the results of the colonoscopy first of all. So here we can see already, quite obviously from this, a mass lesion is identified in the sigmoid colon. So very polypoid in shape. Also looks like there are areas of ulceration. We can see areas of bleeding associated with it as well, which is correlating with the history that David's given us associated with it as well. And subsequently, they did decide to do a CT abdomen, and this is what we've got here. And you can see these vague outlines, multiple outlines within the darker areas of discoloration within the liver. So again, the report indicating that there are features suspicious for liver metastasis with this patient. And again, looking at the previously deranged LFTs, looking at the low albumin as well, would correlate with this. So this unfortunately does not look good news of this gentleman so far. So the patients then subsequently, they've opted and discussed in the MDT that they want to go for surgery. And so what we've got now is this resection specimen that's been sent to the histopathology lab. So I'm going to come to my colleague, Katie. Katie, if you were met with this specimen in the lab, what would your next steps be? How would you go about handling such a specimen?
Hi there, Matt. Well, I think the first thing to kind of think about when we're going to approach a specimen like that is what do our colleagues in the MDT want to know about this specimen, and ultimately the patient themselves. We already know some details, obviously, from our radiology colleagues from the colonoscopy as well. And I think what we can see here on the specimen kind of all fits in very well with all of that. So I think what we want to do at this point for our colleagues of the patient is to be able to confirm the diagnosis or not of what we already suspect, be able to inform the prognosis, and then help plan the treatment of this individual and focus there on an individual and that treatment being specific to them. So we want to first describe the specimen, and then we want to appropriately sample it so that we can do things like the staging, the grading, and then the molecular status. So we've got a specimen here that we would want to first of all describe what it looks like. We'd also want to describe the size of it as well. And I think one of the first things to kind of zone in on after that is then this tumour that we can see in the centre there. And we can see that polypoid tumour that you could also see on that colonoscopy. But what we can also see is that there's also another lesion there as well. There appears to be another polypoid lesion, and we'll be wanting to sample that as well. So we'd want to give the site of the tumour, we want to give the size, the measurements, how far that is away from the longitudinal resection margins. And we're going to want to also kind of turn this specimen over, have a good look into that fat as well. Can we see any signs of any perforations, peritoneal cavity at all? Because we know that that is a well-known adverse prognostic factor. After we've had a good look at this specimen as a whole, we're going to want to start sectioning through it. And we would section it kind of 3 to 4 millimeter intervals through our tumour, and then we would lay that out sequentially. We're going to want to have a look at the tumour itself, have a look how far that has spread so that we can give an idea of that staging. We want to see, is there any macroscopic venous invasion that we can see? Because again, this is important for our staging. Can we see any perforation at all, as I described? We may be able to see that through. Is there any peritoneal involvement here? We're also then going to want to think about what we're going to want to sample to look at microscopically, and how important that is for the patient. So one of the things we need to know is to sample the deepest tumour penetration. We're going to want to sample if there is any peritoneal surface involvement. We're going to want to sample anywhere where we can see any venous invasion. Any adjacent organ involvement isn't really relevant here with this one particularly necessarily. We're also crucially nowadays, as well as we're stepping towards like really individualized medicine, a block for further testing as well for things like immunohistochemistry testing, particularly for things like mismatch repair status, but also other molecular status. We're going to want to take a block of normal tissue as well. And we're also going to go through all of this fat that's attached here in this mesentery. We're going to want to search for all of the lymph nodes that are in there. We will be sampling all of those with particular attention to the highest one by the vascular tie. And also as well here, we've got a separate lesion as well. We're also going to want to be sampling that as well so that we can have a look and see what that polyp is as well.
Brilliant. Thanks, Katie. It's a really nice summary of there's quite an extensive amount of work that needs to be done on such a specimen like this. It's not just a matter of taking one bit, is it? And just looking under the microscope. So again, quite a complex process for quite a large specimen like this. And as you mentioned, it's not just one lesion we've got here. We've got another one that we need to be careful and pay particular attention to. So I'm now going to just, while you're there, Katie, we're going to move on to the next slide where we've got on the left-hand side just a representative bit from the tumour. And then on the right-hand side, we've got a section through that polypoid lesion there. Do you have any comments about these? What do you think we're looking at here?
Yeah, absolutely. So I think with the main tumour, I think even if you haven't seen a lot of histology before, I think if you think back to kind of medical school and you think about those nice kind of test tube shaped crits that you're used to seeing, this looks completely different to that. We've got quite an irregular architecture going on. That kind of nice tubular pattern has been lost. We've got central necrotic debris in the middle of these. The nuclear polarity is gone as well. It doesn't look like a kind of normal glandular formation here. So to me, this looks like an adenocarcinoma. And if we look at the polyp as well, I think you can see that it's a really nice section through a polyp here where we can see that beautiful polypoid structure. We can see those kind of fibrovascular cores that are stretching out. And we've got some areas that look a bit more kind of tubular in the shape, but we've also got some kind of finger-like projections going on as well. I don't know, this is all kind of low power, but to me, this looks like a tubular villus adenoma with some only low-grade dysplasia. So by definition, an adenoma would have some dysplasia. We're not seeing a lot of the features that you can see. It's nice to have them side by side. We're not seeing some of the features that we can see, like that loss of nuclear polarity and things that you can see in the carcinoma. So we can see that there is an abnormality there, but this isn't carcinoma as well. This is a separate polyp.
Brilliant. Thanks, Katie. So we've got evidence of an adenocarcinoma on one side, and then we've got evidence of a tubular villus adenoma. And just to comment as well, they are associated, I think, around 6.7% chance of then developing into tumours. So again, it's almost a spectrum here of what we've got. And it's not unusual, is it, sometimes to see evidence of, particularly in the high-grade polyps, where there is evidence of invasion within the stalk and going into what looks like a polypoid structure is actually, in fact, a tumour, perhaps at the early stages as well. So really important to assess them extensively. Right, I'm just now going to move on to another bit of an investigation. So in histopathology and neuropathology and pediatric pathology, and just like everywhere else, we have to know what normal looks like. And again, it's the same with chemical pathology, hematology, immunology. Knowing the normal is important for us to be able to understand what the abnormal is. And this is another investigation that we can do in histopathology called immunohistochemistry, which is basically trying to identify the little proteins on the surface of the cells and different parts of that. And we've got 4 here, Katie, that we're looking at in terms of this tumor, the adenocarcinoma that we've just looked at. Do you want to just talk us through very briefly about what this indicates and why we do these in these tumours?
Yeah, so in particular here we are looking at that mismatch repair deficiency that I mentioned briefly before, and we're looking at the 4 different, the labeling here with a kind of antigen antibody process that we're taking advantage of is for those 4 mismatch repair proteins. So we've got MLH1, MSH2, MSH6 and PMS2. Normal expression in these would be seen as nucleus staining brown. So that would be positive staining. And what we're trying to see is if there's been any loss of expression at all. Now, these proteins occur as like heterodimers. So they're paired. So MLH1 is paired with PMS2, and MSH2 and 6 are paired. So you're probably starting to see a pattern here anyway. In the MSH2 and MSH6 have been retained, and MLH1 and PMS2 have not. And the other thing is that MLH1 and MSH2, they can stabilize in forming heterodimers with other proteins, but PMS2 and MSH6 can only exist stably with the other two present. So in seeing that we've got an MLH1 deficiency here and a PMS2 deficiency, this means that that PMS2 is also gone. This means that we've got an MLH1 deficiency.
Lovely, thanks.
Sorry, I don't know if that was clear enough.
No, that's great, Katie. I think the important thing really is to show that where mismatch repair is a subset of colorectal carcinomas can be affected by this, and so it's an important way that we can actually very quickly screen these tumours for the presence of this, and we've quite nicely demonstrated this loss in those particular two, which, as you said, is likely to indicate probably most likely an MLH1 deficiency or a mutation associated with that. So what we're now going to want to do is do some follow-up with our molecular testing, and you mentioned in your assessment of the specimen, that's an important thing for us to do, is to take a sample for other investigations. And molecular is really transforming our specialty as well as other specialties related to this. And what we've got here is, you can see on the right the results of the left, the DNA sequencing, and we've identified an MLH1 mutation in the tumor, but also crucially, just to mention, that was identified in the germline of this patient as well, which means that there's a possibility of this inherited and being passed on to subsequent generations as well. And we've also identified a TP53 mutation associated with this case. And one other thing to mention is we've also done our RNA sequencing, and in a small subset of colorectal carcinomas, as well as a lot of others, there are potential fusions or translocations, and in particular NTRK alterations that can occur. And the importance of identifying these at this stage is because they are targetable now. And for a tumor that's potentially high grade with a poor prognosis, finding a targetable alteration that has a drug targeting it will be really important at this. Do you have any comments about these results in addition to what I've said there, Katie, with regards to that DNA sequencing in particular?
Oh, I think you've explained it really well, to be honest. Yeah.
But it is, the molecular pathology really is a crucial part of our day job now, isn't it? Whether that's histopathology or neuropathology, it really is part of our working working lives.
Yeah, absolutely, and it's definitely caused a bit of a kind of adaptation to the way that we work, incorporating those extra bits of the reporting into our reports and kind of taking ownership of the results and allying them together with the macroscopic and microscopic that has been reported for some time. And it also has a key kind of, as I was mentioning before when I was talking about our macroscopic approach, it definitely does have an effect on our sampling in particular, and being very, very aware of how much tissue that we have, not just in colorectal, but in all of the different types of material that we get sent to us in the lab. Taking something like lung as an example, where sometimes we'll only have a tiny biopsy, and how carefully we will treat that tissue and making sure that we've got enough material and it's got the right kind of thing in it to be able to send it off for all of this testing, as well as do all of the other things that we have been doing for kind of decades on this material as well.
That's brilliant. Thanks very much for your input into the case, Katie. That's fantastic. So we've now got a little bit more clinical input. So the patient is discussed in our MDT because, again, we've got further results now, and a treatment plan is put in place, including the use of immune checkpoint inhibitors. So I'm just going to draw on my colleagues actually from both immunology and hematology, Patrick and Thomas again. Patrick, do you have any comments about the use of immune checkpoint inhibitors and what they are and why they might be used in this case, just initially?
Yeah, so I think immune checkpoint inhibitors is essentially a class of primarily cancer drugs used to, if you like, stimulate or make the immune system more active. The immune system, I guess, primarily is intended to fight off infection. And say if somebody catches a bacterial infection or flu or something like that, the immune system essentially activates. And most people are familiar with this. You kind of get a fever, you feel unwell while the immune system is working. But what the immune system also needs is some way of turning itself off. So once the initial infection is gone, it needs to switch itself off, really. And if you like, that bit kind of referred to as immune checkpoints. One way that cancers have of evading the immune system so that the immune system doesn't attack the cancers is to, if you like, use these checkpoints or trick the immune system to not working by using these checkpoints. And what checkpoint inhibitors do is they remove the checkpoints or remove these blocks and then allow the immune system to essentially work against cancers or anything else.
That's brilliant.
One of the obvious side effects from this with a sort of immune system that's activated is obviously you can get inflammation or uncontrolled immune activity.
That's lovely. Thanks very much for that, Patrick. We'll see how our patient then subsequently does with this. So they've been started on their immune checkpoint inhibitors, but a few weeks after the onset of treatment, the patient begins to feel quite unwell. He feels quite hot and sweaty. His breathing becomes quicker and he has a temperature as well. I mean, he's been suffering from a cough, which has been getting worse and is now very productive. And an X-ray is done, and hopefully I can convince you that there's a little bit of opacity that's located in both lower lobes of both lungs here, perhaps a little bit worse on the left-hand side, but definitely some opacity that's developed there compared to his previous normal ones. So as a result of these symptoms, blood cultures and virology are undertaken. And so the culture result to date is negative, but they find positive CMV antibodies, particularly the IgG is positive, but the IgM is negative. And also to confirm this, a CMV PCR is done, which just confirms the positivity associated with it. And other viral screens are negative at this stage as well. So let's call up our microbiology and infection colleagues here. So I'm going to come to Ian. Ian, can you talk us through what you think about these results in this context of this patient and what with the treatment he's had?
Yeah, thanks, Matt. It's a really interesting one. One of the challenges we've faced in infection management over the last decade or two is the evolution and expansion of advanced immunomodulatory therapies. And although checkpoint inhibitors aren't directly immunosuppressive, they're altering the way in which immune functioning occurs. And if you think about it in the context of this individual, we already know them to have a metastatic malignancy, which will itself confer immunomodulation. So when he then presents with a febrile illness, this is not your common variety risk individual walking in off the street. So you can see that this was accounted for in the investigations that were done. Screening for bacterial infection via blood culture is absolutely the right test to do, hasn't yielded you a result. You've looked for respiratory viruses, which obviously over the last 5 or 6 years that we've gone through is a very sensible thing to do, but you haven't got a hit there. Now, it's interesting, we've come on to CMV serology. So CMV for the group is a beta herpes virus. And the interesting thing about the serological pattern you can see there is not supporting acute infection. It's suggesting this individual's had prior exposure to CMV. Well, the interesting thing about herpes viruses is that they have the ability to produce latent infection. In essence, you have a primary infection when you're young and immunocompetent, and it's either asymptomatic or doesn't cause you very much bother. And then at the point at which you become immunosuppressed later in life, the virus has the ability to reactivate. And unfortunately, in an immunosuppressed population, either primary or reactivating disease carries much more morbidity or mortality. So an individual with 20,000 international units per mil of CMV in their blood presenting with bilateral reticular nodular change on a chest X-ray, you'd be very worried about CMV disease with CMV pneumonitis. And this is one of the most severe phenotypes of reactivating CMV disease, carrying a fairly significant mortality risk. So you definitely want this individual in and on targeted therapy.
Brilliant. Thanks very much for that, Ian, and thanks for correlating again what we've got on the X-ray findings associated with our results here as well. That's excellent. And just for interest for the audience, these are if a biopsy was ever to be done of perhaps this lung, the lung associated with this, one of the things histopathologically we can identify is virally infected cells with the CMV have this halo appearance with this very dark staining nuclei, which stand out quite nicely in the image on the left-hand side here. They're what we describe as owl's eyes. And certainly these are things when you see these, it's almost an instantaneous thought that this is likely to be CMV infection. On the right-hand side is an immunohistochemistry stain, which again further confirms that that's in fact what this is in this particular case as well. So we've got a complication going on here for this patient. So things are getting a little bit worse for him, but also now, just more generally, the patient shows good response to the treatment. The liver lesions, in fact, are actually showing evidence of reduction in size. However, one of the things he's been noticing for some time, but it's beginning to get worse, are chronic headaches associated with nausea. And actually, he has a seizure whilst he's out walking his dog with his wife and is taken to A&E, and he has a CT scan of his head. And this is what we're seeing now. So if we're just to orientate those who are not familiar with CT scans, we have to look at these as if we're looking at the bottom, we're standing at the bottom of the bed, the patient's nose is at the top and the back of their head is at the bottom. And so we've got this lesion that's present in the patient's left frontal lobe. And what we want to think is, what do we think this actually is? So I'm going to ask Carl to set up the poll again. What do you think this lesion might be based on the clinical history that we've got of this patient? So let's start the poll. We'll give you a few seconds to have a think about what it might be. A couple more seconds, and we'll close the poll now. Carla, so what does everybody think this was? Oh, so a mixture of things here. We said, so people think abscess could be a possibility, and that's very reasonable, again, given what we just heard about as well. Metastatic colorectal carcinoma is second on the list as well. And again, that's definitely a possibility, given he's already got liver metastasis and an extensive adenocarcinoma that we've seen as well. Primary brain tumor, 5%, and hemorrhage and bleeding. Hemorrhage and bleeding definitely will be lower down on the list, not typical for that appearance based on what we're seeing there. No evidence of neurodegeneration, I agree, but certainly primary brain tumor, that might be something we need to think about given his clinical context and what we certainly identified with the mismatch repair based on the genetic results from this screen. So we'll move on and see what else we can get from our history now with this. So a bit more clinical history now. And I think this is an important message throughout this whole diagnostic process. Correlating with the clinical teams who are looking after the patient is really important for a pathologist to keep up to date with this. So we're regularly looking at radiology. We're regularly getting in touch with our colleagues who are face-to-face with the patients to find out more information about them, and also discussing in the MDT. So the case is referred to the neurosurgeons who discuss the scans at their MDT meeting and decide to conduct a debulking procedure. However, the patient is assessed by the anaesthetist and is not well enough to go through such a procedure at this stage. And sadly, he continues to deteriorate with signs of increased intracranial pressure and passes away. And a post-mortem examination is requested. And this is another part of the work of cellular pathologists. It's not all cellular pathologists do it, but it's certainly around 5% of the clinical work of a cellular pathologist might be doing autopsies. And these can either be those that are referred by the coroner, where there's an unknown cause of death as one of the reasons that you may want to do one, but also hospital autopsies where the clinical teams are uncertain about what the cause of death was, or think there's some valuable learning that can be gained from doing a post-mortem in a case such as this. So first of all, we're going to have a little quiz about what we think some of the histology. One of the things you, of course, do in a post-mortem is assess the macroscopic appearance. So just looking at the organs and deciding whether you can see any pathology based on that. Again, referring back to the clinical history. But you may also want to take some histology to have a look at down the microscope as well to further confirm the diagnosis. And so we've got this particular picture of a histology from an organ here. And now again, a quick poll, Carla. What do people think this histology actually shows? Liver, kidney, skin, lung, or heart? What do people think? And we'll close the poll now, Carla. And the result. And the most people thought it was kidney, and that's what it is. Well done, everybody. And then the next one, this is another bit of histology taken from another organ system. And we're going to do the poll again. What do we think that histology showed? So again, a quick flash of what we think it might be. Just a bit of normal histology, and we'll close the poll now. What do people think? Oh, a bit of a mixture there. So we've got the most people think liver, then followed by skin, then followed by brain. And in fact, it is brain. It's a piece of normal cortex. But again, just as I mentioned earlier, learning the normal is very important before we can understand what the abnormal looks like. And now just looking to the brain, because that's where our particular interest was, these are some of the key findings that help us to understand what's been going on with this patient. And we're looking at here in the left picture, part of the cerebellum. And we've got the pons towards the bottom, and we've got part of the medulla, and the cerebellum around the outside. But what I'll draw your attention to is, in fact, these grooves that are around this here. These shouldn't be here. And that's occurred as a result of the cerebellum being pushed down through the opening, the foramen magnum, which is giving the bony edges of that are causing this pressure effect associated with the cerebellum, which is then being pushed against the brainstem. And then when we look at the section through the brainstem, and particularly we're looking at a level of the pons here, you can see these dark areas of discoloration, which are areas of hemorrhage. And these are direct hemorrhages, and it's the result of raised intracranial pressure. So that lesion in the brain, something has happened to cause the pressure pressure to increase suddenly, and it's caused the brain to move down, and it's caused the cerebellum to push down through the foramen magnum. And so that is the likely cause of death of the patient, why he's deteriorated so rapidly. And then when we look at the histology of it, the picture on the left-hand side, this is again part of that lesion. We've got lots of cells, lots of different sizes and different shapes. We've got areas of necrosis as well, where there's pale area towards the bottom. And then on the right-hand side, we've got areas where there are little vessels that are proliferating as well. And these are all signs of a high-grade tumor, most likely a glioblastoma. So let's see if we can actually try and pin this together and piece this together. Why has this patient got, it's not a metastasis, it's not an abscess, it's another type of tumor. Well, the sequencing that was done on this, again, we sent it off for molecular analysis and we look at the DNA. And instead of perhaps 5 or 6 different mutations that would normally be associated with this tumor, there were 5,010 different mutations identified for this. And so this is what we call a hypermutator phenotype. And one of the things I'll draw your attention to is this MLH1 mutation, similar to what we saw with the colorectal carcinoma mutation. This again is a mismatch repair mutation, which means that we then get microsatellite instability and the potential of multiple mutations occurring in this tumor. One of the other things that we do in neuropathology is we can use what's called DNA methylation profiling to help us. So a few years ago, it was discovered that if you take the DNA from any type of brain tumor and look at where the methyl groups are added along that chain, you will find that each type of brain tumor has a different profile of where these methyl groups are added. And so it can help you, if you're really struggling with the diagnosis, it can help you to classify what type of tumor it is, or to identify what type of glioblastoma we actually have. And the picture on the right here shows you each color represents a different type of high-grade glioma or glioblastoma, and each dot represents an individual case. So the ones that are similar to each other all cluster together in these little clouds. And if we add in the result of our case, we find that it lands in this group called the high-grade glioma RTK1A group. Don't worry about the name of that, but what that group is associated with or enriched by are tumors that occur in a background of Lynch syndrome, which is a type of tumor predisposition syndrome, and that's likely to indicate what this patient has. So our diagnosis is a metastatic colorectal adenocarcinoma. We've got a glioblastoma, which is an aggressive type of brain tumor, an underlying diagnosis of Lynch syndrome, particularly associated with that MLH1 gene mutation that we identified in both the colorectal tumor and also in the brain tumor as well. So very quickly, just a little bit of background about Lynch syndrome. It's also known as hereditary non-polyposis colorectal cancer and is an autosomal dominant condition with a high risk of colorectal cancers and also other tumors as well, which are listed here. And around 1 to 6% of patients with Lynch syndrome can develop a type of brain tumor, and most frequently it's a form of glioblastoma. The mutations associated with this occur in the mismatch repair genes, and you saw the immunohistochemistry of those 4 different genes earlier on. They're MLH1, MSH2, MSH6, and PMS2. And the reason why this causes so many problems is that these genes are crucial for correcting DNA replication errors. So if one of them is knocked out, then it means these replication errors can't be repaired, and so they continue to accumulate, and that's puts them at increased risk of the patient at increased risk of developing a tumor. They typically develop tumors at a younger age. I think the median age of colorectal carcinoma in these patients is around 40. So our patient is 47. And the condition accounts for around 2 to 4% of colorectal cancers. And this diagnosis is quite complex. So again, the thing that's missing from our history here is we needed a family history associated with this as well. But also there needs to be consideration for genetic screening as well for subsequent members, particularly because of the germline positivity with it as well. So I hope that's the end of this case. So hopefully in this example, it's shown you or showcased an example of how pathology specialties can be involved in very complex cases, but all of us have a role to play within this and work together to make a diagnosis. We can either get on the phone to each other, or we can just walk down the corridor to each other's offices to talk about these various different things. But we're all working together to try and bring the jigsaw pieces together. So I hope you found that interesting. I'm now going to stop sharing now And we're now going to move on to our live Q&A session. So if I could ask our panel of attendees tonight to switch on their cameras, and for the delegates who have joined us, if you want to ask any questions of our panel, please, you can see the Q&A function at the bottom. Please don't hesitate to put any questions you want to ask in. There are no silly questions, and we'll do our very best to answer them. And we've got a couple that we've already had so far. So we'll start off. We've got a question. How should I be demonstrating leadership in the specialty application? Is volunteer work with a charity relevant for this? Perhaps I'll come to Katie first of all. What do you think about that from the histopathology side, Katie?
Yeah, I mean, absolutely. I think that kind of experience is really relevant. I think actually drawing on anything where you've got leadership experience is a good example. I don't think it necessarily has to be within medicine itself. But I think also you can show leadership opportunities within medicine as well, whether it be through organising different things, wherever it is that you're based at the moment, things like teaching. There's all kinds of different things that you could probably draw on kind of locally as well as things outside of medicine. I remember when I was going for my interview, I know I used examples from kind of within my working practice, but I also used examples of where I'd kind of shown leadership at university as well in kind of organising different activities. So I think there's plenty of kind of variety of things that you can draw upon. Yeah.
Thanks, Katie. Ian, do you have something to add to that as well?
Yeah, I think I think having a diverse set of skills and working outside of or demonstrating interests outside of work is always helpful to applications. So I often get this question from trainees I'm supervising going through applications. I suppose what we try to do is make your time as efficient as possible. So one way of demonstrating leadership is often, I find most effective, is to run a training program in something you're interested in. You can demonstrate the leadership by being the individual who's manning the rota, getting the speakers, but also you can then direct that educational activity towards your own interests, your own development. There's nothing better than learning a subject to teach it to others, and as far as solidifying your own knowledge in that field. So yeah, try to put your money in something that's going to get you as many points on an application as possible.
Brilliant. Thanks very much, Ian. Thank you. We've now got a question about histopathology interviews. So do you have any tips to perform well in them? I'm going to come to Elsa, who is a histopathology consultant joining us tonight. Hi, Elsa. Do you have any advice for people about preparing for histopathology interview?
Yeah, so that's a really good question. I think first of all is to speak to trainees already in the program. So somebody like Katie or somebody who's just got into the program successfully, and then they would have had recent experience with the interview process and what you're expected to do and prepare for. So having an idea of how it's set up, what's expected, what consultants are looking to see in your portfolio. Some understanding of histopathology, organizing a histopathology taster program with your local hospital would be a good start as well, because then you'd get to see whether really the job is something for you. And just understanding that you can do many things in histopathology, not just, commonly people think, oh, you have to do autopsies, but actually that's not the case. So just getting a real life experience, first of all, is key to your preparation. And then trainees will be able to advise you, or anybody who is on the interview panel would be able to advise you what things you need and what people will be looking for. Yeah, pretty similar across the board, I think, for other medical specialties, but, with a histopathology slant.
Thanks, Elsa. Yeah, and I think speaking to previous people who've gone through that, we're a very friendly bunch of people. So actually talking to previous SD1s is a really important to see how they approached it as well is really useful, and maybe even doing some practice with them. Thank you. So we now got an important question. What sort of research would you suggest getting involved with as an undergraduate? And do you have any advice on doing this? So research is really important as part of pathology, and it's sort of integrated into our specialties really, which is fantastic. Patrick, I see your hand go up. Would you like to
Well, it wasn't about the research one, but just backstepping one to the leadership question from earlier. Okay. Just something to point out for people applying to specialties under the physician recruitment program. So that'll be things like hematology, immunology, and the medical infection specialties. They're actually removing the leadership scoring thing from August 25 onwards. Doesn't mean you shouldn't do leadership stuff. You really should. But if you're trying to maximize points, you may want to read it very carefully what they're scoring for.
Well, thanks very much, Patrick. Thank you. Dana, can I come to you about your thoughts about research and as an undergraduate? And do you have any advice from the sort of hematology side about this, or just more generally as well?
Yes, of course. So I think there's many things you can do in research. Later on, I guess, during your training, you can go into a PhD and do more lab-based work. But I think even at undergraduate level, I know me and others have got involved by writing a case report. And I'm sure if you go to your teams and your consultants, they'll find interesting cases for you to contribute and write a case report, or see patients on clinical trials is more complicated, but that will happen also later on when you're in training. And what else in terms of research? I guess case reports would be interesting, and just don't go and visit the lab. For hematology, you can go and visit the lab. We'll show you, what things are and what we do and how we use the analyzers. We can show you how we review bone marrow biopsy. So there's various things you can do to get more involved in research. I guess quality improvement and audit also comes into this. There's lots of projects always waiting to be done at work. So go and ask your teams and get involved in quality improvement projects and present your work at national and international meetings.
That's fantastic. Thanks, Dana. And yes, I think that the engagement in research just continues once you're a trainee as well. So I've done a PhD, and Katie's involved doing hers at the moment as well. And I'm sure many others have been involved in various different research projects. We're never in short supply of requests for support for these as well. And that goes across all the specialties. So it's definitely something, if you're interested in academic pathology, there is a wealth of opportunity to get involved in this. I'm going to come to Jessica now. We've got a question, Jessica, about what types of patient-facing work do chemical pathologists do in clinics? Can you provide some information about that?
We do lots of patient-facing work. So we run lipid clinics. We do metabolic bone clinics, which involves, mostly DEXA scans, like any other metabolic bone clinic. But there are also, the weird and wonderful things, and other disorders of calcium and phosphate metabolism. Renal stones a little bit when it comes to that. There are inborn errors in metabolism. So you've got the clinics, and that can also involve inpatients as well. Quite often we don't tend to own our own patients. Like on a ward, we tend to offer advice while they're being looked after by other specialties. But if you see inborn errors in metabolism, you've got all your weird and wonderful things. You can get involved in nutrition clinics. So either with TPN home or as an inpatient in ward rounds. And then you've got obesity clinics as well as part of our training. Diabetes is a big thing as well. So for part of my year, I did a year of diabetes training as a Daphne doctor. Work, just doing the same. You see patients, you do all their diabetic foot checks. You adjust their insulin. I feel like I'm missing something. Endocrine as well. Sometimes you can do endocrine. Get involved in endocrine clinics. It's quite flexible, really. For what patient facing specialties you are, depending on which type of consultant and how you want to do it. You may do more or less of the of having a clinical workload alongside with the lab. So, but we there are lots of different patient clinics that you can get involved in and be seeing patients every day if that's what you want.
Brilliant. Thanks very much, Jessica. Thank you. We're also lucky enough to be joined by Joe Brinklow, who's the Director of Learning for the college. Welcome, Joe. Nice to have you with us tonight. I was just wondering if I could ask you a quick question about sort of the changes to training on the horizon at the moment going forward with, if you've got sort of any pointers in terms of the curricula and how that changes. And also there's a question about, there's a non-EU international medical graduate. Can they enter histopathology training programs as well? Do you have any thoughts about that?
Yeah, sure. Hi everyone, nice to be here this evening. So firstly, just in terms of the curricula are all sort of fairly new. They were all published in 2021. And what we're doing at the moment is really reviewing those curricula now, just in terms of the implementation, looking at feedback from trainees, from TPDs and heads of schools. So we've done that with chemical pathology already, and we'll be working through that with the other specialties. If there are changes, those changes will happen as a result of all of that feedback. So there's not any major changes that I can definitely say on the horizon. What I would say, though, one of the things that we are reviewing at the moment is how we review training that trainees have done either prior to entry to training, out of programme training as well, and looking at how we can better recognise that. So at the moment, for example, there's a shift from only allowing prospectively approved training to be counted towards your training period. And we will be issuing guidance probably by the end of the year, looking at how we can go back to how we used to do things many years ago, and that's for doctors that are coming into a programme with prior experience, how we can recognise that. So it won't purely be based on time, because our curricula are all high level outcomes, so we'll be looking for doctors to show us how they can demonstrate where they've got to and where they need to go and things like that. But that's quite a change from how things have been done in the past, and is making things a bit more flexible. Just in terms of non-EU doctors, yes, my understanding is that you can apply for entry to specialty training. And I've noticed, I was just looking up some information, but I've lost the question because there's so many questions. Somebody else is asking about the CREST form,
Yes.
which is about the certificate for eligibility to specialist training. So that is a form that is normally for doctors who have not completed foundation in the UK and generally have undertaken their medical degree outside of the UK. So I'll try and include a little bit of that. So yes, you can apply, but you do need to make sure that you're following all of the guidance in order to demonstrate eligibility. One of those things is the CREST form, and I think the CREST question was asking about how long ago the experience had to be, and I couldn't quite find the answer. But what I would say is that it's probably best to go back to the medical recruitment team, and I'll pop, if I can find the question again, I'll pop the website web address in there, so you can go back to them and get the definitive advice.
Brilliant. Thanks very much, Joe. I'm going to come back to Ian now. We've got a couple of micro ones for you, Ian. So first of all, is there an option to do infectious diseases alongside another discipline? And is there any way to do infectious disease pathology without doing IMT?
Oh, no. Everyone always asks that question, but no, unfortunately, infection or infectious diseases now sits behind the firewall of getting through the IMT first 2 years. So no, there isn't a sneaky way around. In terms of your options, once you get through those 2 years, the world is your oyster. So infectious disease and acute medicine, infectious diseases and general medicine, infectious diseases and medical microbiology, infectious diseases and tropical medicine, infectious diseases and virology, or any combination of those CCTs of different disciplines. It's a very bespoke training program, and yeah, you can pretty much specialize in your area of interest as long as you've got a local program that's happy to support you. But no, there isn't a way of cheating yourself out of the medicine years. But equally, if infectious diseases is what you want to do, having a really good grounding in general medicine is a key component of that skill set. So I wouldn't talk anyone out of not doing those years. I think it sets you up really well.
Brilliant. Thanks very much, Ian. Thank you. I'm going to come to Katie now. Katie, we've got an interesting question. May I know what from a delegate who said, they would like to know what the challenges of histopathology are. Do you have any thoughts about what the challenges within training might be?
I mean, I think, as in all branches of medicine, there are various different challenges. I think one of the first ones that you kind of notice as an ST1 is just how different it is from other branches of medicine. I think sometimes that can be a little bit challenging. I know that because I came from this, as you did, Matt, from doing surgery beforehand, and I felt like I'd suddenly put the brakes on completely. I would say that it feels like it's very, very different. You're not kind of dealing with patients, and that can be very, very different as well. And I think just kind of dealing with that kind of different type of work and adapting to that, it being a little bit more, let's just say, not alone in what you're doing, but kind of working as part of a team very, very differently to how you would do on a ward. I think you have quite a steep learning curve. You have to learn things quite quickly, and it's very different to what you've been learning for the past few years. It almost feels like going back to med school. You also feel like you've had a certain level of responsibility almost kind of taken away as well. There's a very nice aspect to histopathology, which is that you co-report everything for a number of years with a consultant, which is really, really lovely, actually. And you feel very, very well supported. But some of the challenge of that when you first start off is just that you do feel a little bit like, oh, goodness me, everything I have to do, I have to have my hand held initially. As you start to go along and then you start to become more and more independent, do a little bit of independent reporting, that all changes. I think that's probably one of the most challenging things I found initially. As I say, yeah, I do think it's a steep learning curve. And I think it takes some getting used to doing things in a different way.
Brilliant. Thanks, Katie. I'm going to come to Thomas now, if that's okay, Thomas. We've had a few questions, sort of more general questions about what people should do as a fourth year medical student or as an undergraduate at their stage now to get into pathology. Could you give us your perspective on the hematology side? What should they do at their stage, or what did you do at your stage to try and boost your chances of getting involved or to explore more about it?
Yeah, certainly. I mean, a lot of things have already been said, of course. Trying to get involved in the project is useful to do, to demonstrate your commitment towards a specialty. So we had research projects, but audit projects, of course, as well. Trying to complete the audit cycle is always going to be more effective than just doing lots of different audits, showing impact, showing some changes that you've achieved. That's very important. I think that's a generic thing that you can do in any specialty. Of course, if you make contact with academics, you may get the chance to, for example, author or co-author a review article. That would be useful. Something which you can do from home because it mainly involves literature research. People that publish a lot, they get invited to write review articles. So I think that's a very powerful thing that you could do. Of course, disseminating, which we heard earlier, your work in form of posters at a conference. It's something that's probably achievable. So you could try to target a local or like a national conference, like in hematology, like the BSH, the British Society of Hematology conference. It is doable to get a poster there. So these are the things. And then because hematology is a dual specialty, there's a clinical and a laboratory component. What you can also do is in hematology to do the Barbara Baines courses. They are quite popular. I'm sure they're still out. But there's some morphology courses where you learn how to report the bone marrow sample or look at the blood film. And they sort of build key competences that you'd be expected to achieve by the time of your first or second year as a registrar. Sort of like setting the foundation up. And then Of course, bone marrow biopsy is one of the most frequently done procedure that we the hematology, and you got a chance perhaps if you do a hematology rotation and you just check along with your registrar and see if you can do a bone marrow or two, and then you say you've done the procedure a few times, so that would certainly make your application stronger. So yeah, my tip is just to look at the key curriculum and see what are the competences that you're going to do in your first or second year, and see if there's something you can do to get it started a bit early.
Thanks very much, Thomas. That's really helpful. I'm going to come back to Elsa now, if that's okay. So we've got someone who's interested in histopath training, but has asked, are there good ways for post-foundation doctors to get involved in histopathology-related activities if they don't have close links already? What would you advise them?
I think you don't have close links until you make them. I think that's a thing. So you have to start. I mean, reach out to your local department, reach out to the local medical education department. Try and find contacts that way. I mean, sometimes even speaking to if you're in a clinical specialty, for example, speak to your, if you've got a surgical consultant who's your direct supervisor, they would know a histopathology contact because they would meet them every week at the MDT meeting. So be creative about how you seek out these network opportunities, and I think that's the way most people go about it. Certainly, that's what I did, and I believe most people I know did it that way, because contacts don't just come to you. I think the whole point is that you have to show initiative. You have to be proactive about seeking out these opportunities. And I think most people here are, because they're here today. So I mean, I think any of us would be happy, for any of you to get in touch if you want to contact too. So that's what I'd say. Be enthusiastic and just reach out for the contacts. We'll be more than happy to help.
Thanks, Elsa. I definitely echo that. Definitely. Jessica, you've got your hand up.
Yeah, I was just going to say, when my husband was interested in chemical pathology, he literally just phoned up the duty biochemist and was like, do you know who I could talk to? And they were like, oh, I share the office with the TPD for the region. Here you go. So sometimes you just need to find a way to contact the lab. We're generally quite friendly, and once you know one person, will be able to put you in contact with people in closer to your region.
Brilliant. Thanks, Jessica. And I'll just come to you, Patrick. Do you have any advice for people from an immunology point of view about what they can do?
Yeah, I mean, I think pretty much what everyone else said. You still get taster. I think most of us, particularly in the smaller specialties, are more than happy to sort of welcome people to see what we do. And it's kind of a matter of getting the right contacts, I guess. Someone within the hospital in a bigger special will usually know of our existence. So get in touch. There'll often be projects floating around that can be done. Taster weeks, more than happy people sit in. And then you get some feel of what things are like. So yeah, make contact, I think, is probably the most important thing.
Brilliant. Thanks, Patrick. Thank you. I'm going to come, if Bernie's there, there's a question that's been, is AI a threat to histopathology? But perhaps in terms of more generally in pathology, what's your view on that, Bernie, at the moment? I think it's a common thing that comes up in these events. What do you think?
I think certainly it's inevitable that the AI will begin to feature more in pathology services in the future. We're still a long, long way away from it, because even for image-based AI, which should be used in CellPath, we need a big expansion of digital path first, and even then we need some headspace within the services in order to assess and train and implement AI. It shouldn't be regarded as a threat to histopathology, because and it shouldn't mean that we need less histopathologists in the future. It will just enable us to work more efficiently, do things slightly differently but better, and it should be embraced on that basis. For the non-CellPath disciplines, AI is incredibly important as well, because when you look across blood sciences, we see now we're only at the beginning of developing AI-based algorithms to decide clinical pathways, and that will be the future, whereby we'll get much closer linkage between the pathology disciplines in terms of cascade testing, in terms of deciding what happens clinically to patients, and that way we can speed up turnaround times and speed up decisions to treatment, which will be incredibly important for things like cancer. So AI is the future, but it's not a threat. It will be an adjunct to everything that we do.
Yeah, thanks, Bernie. It's definitely going to be a tool in the toolkit, I think, rather than just like we have with molecular and digital as well. Thank you. Joe, I was just going to come to you. Someone's asked about competition ratios in pathology with regards to recruitment. Do you have any comments about that?
Yeah, I just posted the link.
Oh, sorry.
To the no, it's fine. I was just going to say, so helpfully, someone has put all of that information together going back to about 2017 now. So I've just posted the link in answer to that, so everybody can go and have a look. It's quite interesting actually to look at it across the years too.
And there's been a question about round twos for histopathology, but I expect that information is around there. From my memory, they do hold the round twos if there are places available, depending on what the outcome of the round one was from memory. But again, that information should be associated with that. Is that right, Joe?
Yes, that's right. And I noticed someone else was asking about the timeline for recruitment as well. So I was just having a look at that. But quite a lot of these questions really are for the sort of the medical recruitment team. And also just to say, Matthew, I know we're sort of trying to get through all the questions, but I also noticed if someone was asking if there was going to be an increase in the number of histopathology training posts, and the answer is that we would love there to be, and we're doing everything that we possibly can to make that happen. But at the moment, there's no major change. But please do keep asking so that people know that there's demand out there.
I know it's something when I was the trainee advisory committee and everybody are pleading for.
Yeah.
So it's something the college are very actively involved with, as are other organisations as well. So they're definitely on it. I'm just conscious of time, so we're just going to have a quick finish up on one more question I think we've got here. Ian, actually, there's a question about, can a foreign trained BMS go through to have a training in pathology with emphasis on medical microbiology and infection science? Is there a role for biomedical scientists within your specialty?
Yeah, absolutely. Sorry if my signal's cutting out a little bit, but we work incredibly closely with our microbiology biomedical scientists, and a number of those colleagues have come from training outside of the UK and then entered into the portfolio biomedical scientist program through their work with us. And then even some that I know have gone on to do some of our higher specialty scientific training programs. So there's numerous different parallel training programs that individuals with biomedical scientist training can do to further their work in all aspects of infection. And it's actually an area that the college seem to be expanding and looking to utilize that slightly different but nonetheless useful clinical skill set. So yeah, I'd encourage anyone outside of the UK or with a BMS background to think about infection, because there's huge amounts of opportunities within our field.
Thanks very much, Ian. Thank you. I'm going to draw an end to our panel discussion now because I'm just conscious of time, but I just wanted to thank, first of all the panelists for being here tonight and for providing all the answers to these questions. That's hugely helpful. Hopefully the audience have found that useful as well. And thank you so much for having sent in so many questions. I'm sorry we haven't been able to get through all of them. I think some of them are quite related to some of the answers we've given already. But in the remaining few minutes, we'll try and type a few answers as best we can in the background. But if we don't get through those, we'll try and do this as a frequently asked questions section that we can send out afterwards for the event as well. But it's now my pleasure. Just thank you very much again to all the panel for being here. And I'm just going to hand over to now, it's my pleasure to hand over to Abby, who's the BDIAP trainee counsellor, who's going to tell us a little bit about the BDIAP. Over to you, Abby.
Hi there. Just going to share my screen. Give me 1 second. So can you see that?
Not yet.
Not yet? Give me 1 second. Just give me 1 second. Apologies for the delay. How about now?
Yeah, we can
see
it.
Yep, fantastic. Okay. Right. Okay. Hopefully you can hear me as well. So firstly, thank you everyone for a fantastic session. Really enjoyed that. And I'm so delighted to see so many budding pathologists in attendance. So my name's Abby. I'm a gynecological histopathologist by trade, but I also looked after the ST1 histopathology trainees in Oxford and the histopathology components of the undergraduate medicine course here. So hopefully by now you've spotted that this taster event has been organised by the Royal College of Pathologists in cooperation with an organisation called the BDIAP. And I'm here in my capacity as one of the trainees counsellors with the BDIAP, and I'm here to talk to you about the BDIAP as an organisation and why you might be interested in joining. So the BDIAP, it's one of the major pathology societies which represents the UK, and as the tagline suggests, its aim is to promote pathology through education and research. And I'm very proud to say that the BDIP has supported me all the way through my training. What does BDIP stand for? Well, as it says here, it stands for the British Division of the International Academy of Pathology, which is a bit of a mouthful, but it does remind us that the BDIP is part of a wider global organization called the IAP, the International Academy of Pathology. As our wonderfully colourful flag logo that you can see states, the BDIP doesn't just represent the UK, but also Dutch, Belgian and Irish pathologists as well. Now, in terms of what the BDIP does, it does a range of things, and that includes organising educational courses and symposia, promoting and publishing research, as well as organising scientific congresses. So, as attendees, what does it mean for you and why should you join? So if you're a foundation doctor, the BDIP has a special category of membership just for you. And if you're interested at all in the specialty, which I hope you are after today, it's a bit of a no-brainer as it's completely free. It unlocks a range of benefits, including bursaries to attend a wide range of the events that we help to organize. So that includes things like the joint BDIP PathSoc meeting, the next one of which is scheduled in the wonderful Ghent in Belgium in 2025. And that could, for example, be a chance to experience in a bit more depth the diagnostic principles and scientific background to histopathology as a specialty. And it could also be an excellent chance to present your own research as a poster or otherwise, for example. And there's going to be dedicated sessions in that for undergraduates and trainees, as well as the main program. In addition, the BDIP organizes an annual molecular study day and cut-up study day, which are both extremely popular. Molecular pathology, as you've seen today, increasingly underpins a lot of what histopathologists do, and the molecular study is a great chance to find out a bit more about this. As a trainee in histopathology, you'll also learn to find out about how our job isn't just looking through the microscope. We also dissect, assess, and sample tissue macroscopically. And so the cut-up study day is your chance to find out a bit more about that. And there's a good contingent of foundation doctors who attend these days each year. We'd love to welcome you to this as well. Another upcoming event is the BDIP Annual Symposium, which this year takes place in November and takes a deep dive into breast pathology. As well as the events, the BDIP also produces educational materials, including access to the BDIP workshop program. And if you're a member, you can flick through and watch previous workshops at your leisure on the website members area. Very importantly, I think joining gives you access to us as the BDIP counsellors. We're delighted to offer you general help in terms of organising taster days, career advice, and help provide you with advice within our capacity to those submitting applications. If you're a medical student, the BDIP also offers elective scholarships if you're choosing to do it in an elective in a cellular pathology department, for example. So do please visit the grants and bursaries page on the BDIP website if this is applicable to you. And much like for foundation members, please do get in touch. We'd be happy to help discuss what a career in histopathology might look like for you. As a medical student, you won't be able to join the BDIP just yet, but you can, of course, join the BDIP for free during your foundation year, which will, I promise you, come around sooner than you think. If you're interested in finding out more, the first port of call should be our website, so www.bdip.org, and you can scan these QR codes straight away if you're looking for specific information about how to join grants and bursaries and our events calendar. And you can also find us on X/Twitter, Facebook and Instagram. So I hope that's been helpful. Thank you very much for your time, and I hope to see you all in the BDIAP very, very soon. Thank you.
Thank you very much, Abby, and thanks very much as well to BDIAP for sponsoring tonight's event. Now, there were a number of questions during the Q&A about what you can do to prepare for your application for specialty training in pathology specialties. And so in the next 5 minutes or so, I'm going to point out some of the opportunities that exist for doing just that. To begin with, we heard about the importance of getting in touch with your local department and organising a taster day or days in that department. I would strongly recommend that you do that. As you've heard, most pathology departments will be delighted to host you, but we do also have a way that the Royal College can help you, which is that if you like, and if you think it would help, we can provide you with an official college letter to the head of the department of your choice, asking them to support your visit. And if you'd like a copy of that signed letter, drop an email to the college team and they will send you a copy, and that should help facilitate your taster day. You don't have to use that letter at all, of course, but it is available if you'd like to use it. We do have a small grant scheme for medical electives, which we run in conjunction with some of our specialist societies that you can see on the right there. And you can see that they cover many of the main specialties in pathology. You can find more details of this electives grant scheme on the website. The current round closes for applications on the 30th of September this year, so please do apply. Your elective could be in the UK, like Lucy's on the left, who went to Glasgow to gain experience in forensic pathology, or it might be abroad, like Lola on the right, who went to experience ID in Peru. We also run a number of competitions which might be of interest to you as well for your portfolios. We have an art of pathology competition, which is a fantastic way to explore pathology in a new way. And there's a very generous prize sponsored by Sonic Healthcare. We have an RCPath Science Communication Prize, which is just open until the 29th of July this year, so it's one to get your skates on for, but there's still just time to squeeze in an entry. This is awarded to a pathology trainee, a foundation doctor or undergraduate who's shown excellence in science communication activities. And we have 2 essay prizes which run annually, the Hugh Platt Foundation Doctor Essay Prize and the Paola Domizio Undergraduate Essay Prize. And we get some really fantastic entries for these. So the 2024 winner for Paola Domizio Essay Prize was Alexandra Tanaka. The Hugh Platt Essay Prize for this year hasn't yet been announced, but last year's winner was Dr. Sally Ashton. She's featured on the website, both of them are, and you can read all the past winning essays on the website as well, which I'd recommend. In August every year, we run a free 2-day pathology summer school in London for medical students to learn more about the role of pathology in healthcare. And this is really popular. I think Matt is heavily involved in that. Watch out for that next year. Applications have closed for this year, but it'll be running again next summer. And finally, any undergraduate at all who is interested to be an undergraduate member of RCPath that can do so at no cost. It's free to be an undergraduate member of the college, and that comes with a number of benefits. So head over to the website if you'd like to sign up to that. And with that, we've come to the end of this evening's event. Massive thanks to all of our panelists and speakers and to the President for joining us, and special thanks to Dr. Matt Clark for all his work putting together the mystery case, chairing the Q&A panel, and to Carla Clooney, who has worked very hard behind the scenes organising everything to run so seamlessly. And lastly, thank you all very much for joining us. I really hope that you found it useful and have felt inspired to continue with your pathology journeys. Good luck with with your applications, and have a good evening, everyone. Goodbye.